Hey everyone, this is Dr. Scott Gray from scottgraypt.com. So today I want to talk to you guys about some clinical reasoning with the cervical spine. So what we're going to do though before we do that is go over the biomechanics and just kind of look at the facet joint plane and make some sense of the motion of the neck before we dive into treatment and exercise strategies and manual strategies to improve motion. So if you look here at the cervical spine, you see my finger here, this is called the facet joint. And so you can see they kind of run at this 45-degree angle. And this is important because motion is dictated by the anatomy. And because of that, the cervical spine moves in specific ways. And so for instance, if this is my facet joints, if I rotate my neck to the right, it's going to down glide down and back on the right, but it's going to kind of slide up and forward on the left at a 45-degree angle. And in the cervical spine, mid-cervical at least, it's the same mechanics with side bending. So anytime I side bend my head to the right, I'm going to down glide, down and back on the right, and I'm going to go up and forward on the left. Similarly, when I extend my neck backwards, I'm going to get a bilateral down glide, down and back, and when I flex forward, I'm going to get up and forward bilaterally. And so, when I see other physios, new students, I see them doing evals on the cervical spine, and sure, you need to look everywhere else in the body, but what I commonly see is they're saying, well, what mobilization do I do, right? So they really get kind of flabbergasted by the mechanics of the cervical spine, and they're not really sure, is it muscle, is it joint tightness? And so basically I'm going to show you clinically what I have found from an evaluation standpoint, what you can do to help discern, is it the facet joints that moving, and what plane, or is it muscular tightness, and along those lines. So stay tuned for the next videos. Alright, so now we're going to do some clinical reasoning here. And so I have Pat here, he's got some normal motion, but we're going to play this kind of devil's advocate here. The biggest things that I use are extension, side bending, and rotation for the most part. Usually you'll find people are lacking more extension or a down glide, at least that's what I've seen clinically. So as we discussed in a previous video, when you rotate right, you're going to get a down glide to the right and an up and forward glide on the left of the mid-cervical spine. So for instance, say he was lacking motion to the right. So we could either say that he's lacking in glide up and forward on the left, or down glide back into the right. So you can also postulate or rule that out potentially by having him extend his cervical spine, because when you extend, you've got the same exact mechanics. So theoretically, if he's lacking motion in extension and down glide, he will be lacking it in extension and in right rotation. So then I would have him extend, and if that's okay, then I'm probably not thinking mid-cervical spine. He could possibly be limited at the subcranial spine, which was at the atlas and axis where the majority of motion occurs. Similarly, I could also do side bending this way, because side bending to the right would be the same exact mechanics of the rotation of a down glide down and back. So that's how you can really kind of rule in and rule out. So another thing you want to take into consideration when looking at the movement of your patient when you're evaluating the cervical spine is, just like we did in the first example, of a down glide on the right side, is when they can't down glide, they'll compensate in specific ways. So for instance, if I am going to extend my neck and I don't have motion, a down glide on the right, I'm going to kind of look back and to the left a little bit because I can't down glide on the right. So similarly, when I rotate right, I won't be able to rotate as far, or will I be able to side bend? So those are just some compensations you want to consider when evaluating your patient's movement. Alright, so now what we're going to do is apply this with side bending, and so with that down glide. So for instance, let's just say that he was Pat had normal motion to the right, he had normal motion extending, but then when he would try to go this way, he just wasn't getting as far, right? So you're probably thinking more tightness on this side relative, because he was able to up glide and hit full motion this way on the left, right? He was able to down glide on the right. He was then able to extend back, so he's able to down glide back, so that's not a problem. And then when he goes to side bend, he just gets hung up, right? So you're probably thinking in this case, more soft tissue tightness here. And obviously you can check this stuff passively as well, get a better understanding. So that's just some clinical ways you can really discern, what they really need as far as your patient's treatment goes. Another common movement disorder that you'll see when you do your cervical testing, so the patient comes in with a cervical pain, neck pain, is when they start doing their side bending, if they are lacking motion subcranially, they're going to deviate to the right. So what happens at the subcranial spine is when I side bend one way, I need to rotate the opposite way. And so when I check my spine this way, I'm side bending subcranially to the right. But if I can't rotate back to the left, my eyes will kind of deviate down this way. So in that case, that's a clue you need to do your subcranial testing. In another case, or applying that same information, they should be lacking motion into left rotation as well. So those are some things you can look for as far as the subcranial spine goes.